I will take over the chair from Linda. Thank you, Linda, for getting us this far. We'll start with the short presentations from 4 speakers. I'll introduce them all at the start, and then they can do the detail. They can do the detail themselves. So, firstly, Anna Gilmore, who's a Prof of Public Health at the University of Bath. Secondly, Liz Arnaz, who's a Policy and Advocacy Manager at the NCD Alliance. Then Jeff Collin, who's a Prof of Global Health Policy at Edinburgh. And lastly but not leastly, Will Anderson, who's a freelance researcher, writer and editor. Anna, over to you.
Brilliant. Thank you, everyone. Can you hear me okay?
Yeah.
Great. Even just managed to make a cup of coffee, which is always good. So we think really of the commercial determinants of health to a large extent as being about the products of certain corporations. But as we've heard this morning, practices also play a key part. So I've got the difficult task, I think, of trying to just summarize the practices that are really key here in understanding commercial determinants of health. The next slide. I thought I'd start with just giving an idea of the scale, and this really focuses on the products, and I think this is why we do think of commercial determinants of health as being about these products. And you can see from this that the scale is vast. So on conservative estimates, just 4 products alone account for around 1/3 of global deaths and 41% of NCD deaths. But by other estimates, actually those figures are significantly higher, so up to 78% of NCD deaths globally. Next slide. But a key element really of driving that level of mortality from products is actually the practices. And I think about the impacts that commercial sector practices in 2 boxes, if you like. So on the left, these practices really explain why the scale of harm from those products that we've just looked at, particularly from unhealthy commodities, is so high. So these are the practices like marketing that we've heard about, driving consumption and driving inequalities. Political practices to prevent progress in addressing and preventing harm. So I'm talking here in particular about lobbying and so on. And the scientific practices, including those that Mark talked about, to hide product harms and create confusion in order to delay progress. But then there's another set of commercial practices on the right, which help explain really additional harms, and these are relevant across all industries, not just unhealthy commodity industries. So they might include occupational injuries and exposures. And global burden of disease data suggests that those two add an additional approximately 1.2 million deaths to the total. But there's a whole host of other practices, dumping of waste products, and I think in particular labour and pay practices, financial practices and so on. And these play a key role, in particular, I think, in driving inequalities. I think it's really important that we don't forget these harms, because they're really part of this kind of complex systems in which the commercial sector can harm health and equity. So next slide, please. So this is an attempt at an overview. So a number of years ago, I developed a model that I've been used to kind of drive our work within the University of Bath on this. And trying to understand, categorize commercial sector practices. So on the right, you can see political science and marketing, and we've started to understand in more detail political practices. So there's a vast amount of evidence around the tobacco industry because it had to make its documents public. And so we did 2 systematic reviews of that evidence and then used those to develop here this policy dystopia model. And that really identifies all the practices the tobacco industry engages in to try and prevent policy progress. And then that taxonomy has now been applied to other industries and shown to be relevant to food, alcohol, gambling, pharma. So what we can say is that all these industries use the same practices to try and undermine policy progress. And then we did a similar approach for science, but we took a far broader approach, and we just looked at the evidence around commercial sector influence on science in general, and found evidence consistent across 8 industry sectors, I think it was, that they use the same practices to try and undermine science and the way that science is used in policy. Marketing itself is already pretty well understood, and we haven't looked at that. But what I'll try and touch on today in a bit more detail is the financial and labour practices, the things that we we kind of tend to forget about, but I think are also important. And one thing just to highlight, that in all these practices, commercial sector behaviour can be very benign and ethical, but in some sectors and within some corporations, it becomes unethical, and in some cases actually illegal. And a key issue here is the extent to which those practices are regulated. So next slide, please. So scientific practices, before we go on, there is this clear evidence that all these corporations, and we think in particular of the tobacco industry, doubt is our product is the infamous quote from one of the tobacco industry documents. But underneath that, you can see ExxonMobil's position, which is exactly the same, emphasize the uncertainty. And what our taxonomy shows is they try to minimize any unfavorable science by trying to prevent it being published, by attacking it, by attacking the researchers, and then maximize favorable science by producing their own science and then creating this echo chamber for it. And as Mark has shown, creating doubt about the state of the science. And then the other thing they do, of course, is develop science that offers their products as solutions and helps create these corporations as the solution to the problems that they've caused, and of course, adding to corporate products. And a key element of this is legitimizing their role. And I should have touched on in that bigger picture, of the kind of the rose picture, if you like, the flower picture, that we put in the middle there reputation management, because for particularly unhealthy commodity industries, managing their reputation and continuously working to try and improve their reputation is absolutely key to their ability to operate. So next slide, please. So the worrying thing, given this overwhelming evidence of corporate influence in science, is that the amount of science funded in the public sector is falling, as you can see on the right, and the amount in the private sector is increasing. And the scales on those graphs are different. So really, we're looking at a situation where the ability of the private sector to influence science and understanding and create doubt is increasing over time. Next slide, please. So what about these broader practices? So labour and employment. I won't go into them all, but obviously these have massive impacts. We've talked about poverty and inequalities, and there is absolutely clear evidence that pay gaps have been increasing over time, partly because of executive compensation schemes. So it's not just about salaries, but shareholder schemes. And I've put some data here on the left from the UK, but based from Oxfam. But actually, the gap in compensation between corporate executives and average workers is even greater in the US. And of course, we've also seen this change in labour standards and labour practices. So workers not only having in relatively lower salaries at the time, but also being increasingly subject to informal and 0 hours contracts, which of course has impacts on health, and we saw that clearly during COVID. And that's the case even within the NHS, with porters, for example, on 0 hours contracts have been found to have higher rates of COVID. And these are important because obviously everyone, the other thing is that there's been a shift in employment, of course, towards the private sector. So the impacts of these are felt across the board. Next slide. So also, broader financial practices. I can only just touch on these really briefly, but there's some great work by Tax Justice Network, and what that shows is that corporations, this is globally, are shifting 40% of all profits made abroad into tax havens. And when you add to that the shift in wealth from wealthy individuals into tax havens, a total of 427 billion is lost each year, which is the equivalent to a nurse's salary every second, or 9.2% on average of health budgets. And for low and middle income countries, that proportion is far higher. It's over 50% of their health budget. And of course, it's the high income countries that are contributing the most. So they account for 97% of this tax avoidance. And you can see here, the UK, interestingly, is in second place, both in terms of being the biggest tax loser. And I think it's $10.3 billion, these are dollar figures, that is lost through corporate tax abuse from UK budgets. But we're also one of the biggest contributors to these tax losses. Next slide. So those are profit, those are profit taxes, and this graph also concerns profit taxes. And this is a really nice piece of work that's been done by colleagues primarily in Australia. And they looked at US listed corporations. And what this graph shows is the effective profit tax rate on these corporations over time. And these are corporations that are harmful. These are the unhealthy commodity industries. And what we're seeing is that these costs of the harm that they're causing are being increasingly externalized to society because the effective corporate tax rate is reducing. We don't have those data for the UK yet, but we do know, for example, that tobacco companies are paying almost no profit tax in the UK, certainly the last time we looked at this. So it may well be the same, and that's a piece of work that needs to be done. Next slide. So as a result of these sort of patterns, what we're also seeing, and this comes from the World Inequalities Report, is that the power of the private sector, so the proportion of wealth held by the private sector has been increasing over time, while that held in the public sector is stagnant or falling. So, you know, this growing imbalance in power between those two sectors. Next slide. And it's that really that to a large extent underpins this whole problem, because then they can use these vast resources to influence policy, to pay lobbying groups, to fund the think tanks, and also to shape norms. So we've touched on this, and I think Greg in particular touched on this. This is shaping our norms, values, our beliefs. And it's not just this idea of, you know, blaming the individual, which is the one I put second, but actually they have shaped whole political systems and political norms. So neoliberalism, which is the kind of global political economic system now, was really a kind of obscure, marginal ideology, you know, from von Hayek and the von Pelleren Society. But once the wealthy and the major corporations understood that this could help them because it would reduce regulation and reduce their tax burden, they started pouring money into neoliberal and setting up, in fact, neoliberal think tanks, university business schools, and powerful organizations like the World Economic Forum, so that this has become absolutely mainstream. And again, this is part of the problem. And again, this individualization and blame, their ability to do this has become so extreme that we don't realize that terms like carbon footprint was in fact coined by British Petroleum or littered by the plastics industry. You know, these norms have become to be widely held. Next slide. So closely linked to this is that the reputation management practices. So they've used these are what many of us refer to as corporate social responsibility. And let me just give you one example from 2021. And this was Philip Morris approaching both the government but also local authorities with the offer of funding to help, you know, clean up Britain and address the litter problem. And we need to remember that cigarettes are the single most littered item and the single largest source of single-use plastics. And yet in their website, what are they drawing attention to? Tires. And then they were offering to part of the program was to show this video that would shame smokers for dropping their cigarette butts. So again, this blaming. But the key reason they were doing this was because at the time there was the threat of a mandatory levy. And so you can see the way they can use their funds to try and subvert the policy agenda, but also to try and improve their reputation. Next slide. Overwhelmingly, what they're trying to do here is push for partnerships, but the overwhelming evidence really is that there is no evidence to support the effectiveness of partnerships, particularly where there's a conflict of interest. So because you really need, if these partnerships are to work, they need to share a common goal. And yet we're seeing the government, you know, really pushing for these partnership approaches despite this lack of evidence to support them. Next slide. So another example, and this is from Mark's work, a different page to the ones he really mentioned earlier. And again, this is about reputation management practices. And it builds on work. So there's a lot of work we did in the past looking at the tobacco industry, and that really showed that at best, tobacco industry corporate social responsibility programs were tax deductible public relations exercise but at worst, they were really harmful. They would work against public welfare. And this shows exactly the same thing. So that corporate social responsibility materials around responsible drinking, which were produced by alcohol industry funded organizations such as Drinkaware, the ones that Mark was touching on earlier, encouraged rather than discouraged alcohol use. And yet these organizations are registered as charities, educational charities, despite this misinformation they're producing. Funding to them is tax deductible. And we're seeing government partnering with these sorts of organizations. So this is the sort of position we're in. Next slide. So really diverse commercial practices play a role in generating health harms and inequities. They cause impacts across all industries, not just unhealthy commodity industries. The political and economic system that they have helped establish has enabled these practices and really led to this race to the bottom on labour standards and corporate tax rates. And norm shaping is a key issue that we really need to bear in mind. Next slide, there's plenty we can do, but we can maybe discuss that afterwards rather than touching on it here.
Thanks, Anna. Hugely fascinating. So I'm going to move straight on and introduce Liz Arnands, who is works for the NCD Alliance. So Liz, over to you.
Thank you very much, Greg, and hello everyone. It has been extremely enriching to hear to all the previous speakers, and I'm delighted to be presenting here today on behalf of the NCD Alliance. I will speak about the commercial determinants of health from an NCD and global advocacy perspective, and I will briefly present the Signaling Virtue Promoting Harm report, preliminary analysis of strategies adopted by health harming industries at the beginning of the COVID-19 pandemic. So in the next slide, I would like to start by highlighting the magnitude of the NCD burden, as also done by Professor Ball at the beginning of this webinar. WHO published this September a report clearly recognizing that NCDs, namely heart disease and stroke, lung disease, cancer, diabetes, and mental and neurological conditions, now outnumber infectious disease as the main drivers of preventable ill health and death globally, with the biggest burden falling on lower and middle income countries, where 86% of NCD premature deaths occur. But despite political commitments to reduce the NCD burden, in many cases, the NCD response has remained insufficient, underfunded, and uneven. With system forces beyond the health sector, such as the social and commercial determinants of health, as we're discussing today, requiring reform as part of the NCD response. The NCD movement has recognized the systemic challenges and the risk factors shared by most NCDs, particularly poor diets, alcohol, tobacco, physical inactivity, and air pollution. So commencing in 2009, NCD Alliance came together as an alliance to tackle these risk factors, upstream determinants, and health system challenges together through common solutions. Because the main NCD risk factors are modifiable, a large proportion of NCDs are preventable. And as mentioned by Greg in the introduction, there is a growing burden of multimorbidity. And prevention is also key for those living with NCDs already to achieve their highest attainable standard of health. So in the next slide, please, I wish to highlight that as with the wider determinants of health, NCD risk factors, and therefore NCDs are a political responsibility and not a matter of individual choice. I think this point has been made in several presentations, so sorry for the repetition, but I think it's very important that we get that message through. So preventing NCDs are preventable, require government actions. And we recently had a consultation on the social determinants of health, which I think I would like to highlight that as WHO is approaching the new social determinants of health agenda, they are trying to incorporate commercial determinants within that. In this consultation, we stressed that the importance of governments to have a comprehensive human rights approach. So protecting our right to health also requires policies that protect our right to education and information, to name a few. And two, we need policy coherence at the highest political level. There is no coherence in investing in air pollution reduction and healthier food systems if we keep huge subsidies and investment portfolios for fossil fuel and healthy food industries. And 3, again, here I'm highlighting those messages that we wanted to get through as part of a discussion on social determinants, but also commercial determinants, is that, as highlighted by Professor Gilmore just now, there are huge outreach and power imbalances between government and health-harming industries, which are often led by only a few very coordinated and powerful multinationals. While these industries nearly reach everyone, governments are not doing enough to reach and protect everyone. So governments must be able to measure those outreach and power imbalances and implement policies and regulations that are population-wide to close that gap, as has been reiterated across presentations. So in the next slide, I wish to kind of give a bit of background to the COVID context and how the NCD community reacted to that as part of the current leadership and investment and care gaps that we see in the NCD response, which has is an insufficient progress towards SDG target 3.4, which is about reducing premature NCD mortality by 1/3 by 2030. We are faced with a poor health status of our populations, which has brought fatal consequences with COVID-19, as highlighted by Professor Bold at the beginning, with people living with NCDs being the hardest hit because of being a higher risk of death or severe illness from COVID-19, but also because many of them have been also deprived of access to essential care and timely diagnosis during lockdowns. And lockdowns and other restrictions during the pandemic are having long-term implications on our health, poor mental health, increased exposure to risk factors, and worse social conditions for many. So revealing this once more, that our systems and regulations are weak and vulnerable to these social determinants and commercial determinants. So this was and is a wake-up call for our leaders, as highlighted by the Signaling Virtue Promoting Harm report that I will talk more about in the next slide, please. So as mentioned at the beginning, this was a preliminary analysis of strategies adopted by unhealthy commodity industries during COVID-19. It was led by a Spectrum Consortium and NCD Alliance, and it was authored by Lucy Westerman, a brilliant and former colleague of NCD Alliance, Jeff Collin, who is also presenting here today, Rob Ralston and Sarah Hill. As a crowdsourced project, it gathered over 760 examples of industry interference during the pandemic from 94 countries. And is a preliminary analysis, as it only covers examples from the beginning of the pandemic, as it was the report was published in September 2020. So some of the report conclusions include, as you can see in the graphic, the comparatively small number of tobacco industry actions reported. This shows the significance of having comprehensively regulated tobacco products through the Framework Convention on Tobacco Control and regulating conflicts of interest with the tobacco industry with the Convention's Article 5.3. I will now share a snapshot of main areas of activities by industry that were identified in the report by the authors, and I encourage you also to explore the report in more detail after this webinar. So thanks for the next slide. So the first area of industry activity identify how industry adapted the marketing and promotion and increased the ability of products and also brands in the context of the pandemic. So first, for instance, by appropriating themselves of frontliner workers, donating them unhealthy products like Krispy Kreme donuts, saying that part of the product revenues will go to healthcare systems, including thank you notes to healthcare workers in packaging. Also by giving an image of how their products can help combat the pandemic. Karsten Beer in Brazil with this Lang-inspired marketing that you can see in the image was saying, good beer is like air, you can't live without it. Also by commodifying social distancing and PPEs with merchandise, Zoom backgrounds, masks, social distancers. And also by taking advantage of digitalization. So for instance, increasing ability of online wine sales in the UK via the Get Wine app. At a later stage of the pandemic, we have also seen pubs offering themselves as vaccination centers and free vouchers for unhealthy products being offered to those getting vaccinated. In the next slide, please, another second area of industry activity identified was corporate social responsibility and philanthropic actions by, for example, contributing to COVID-19 funds. This gave health harming industries a positive media coverage and also has leveraged their relationships with many governments. They also supported communities while protecting their core interests, such as with Diageo's Raising the Bar Fund to support bars. They aim to address shortages and strengthen health systems, for instance, with alcohol companies producing hand sanitizers with quite branded bottles, or try to be part of the solution to the pandemic, as also I think flagged by Professor Gilmore. So for instance, with tobacco companies exploring plant-based COVID-19 vaccines. After this report, there's a clear example of this with Canada's Medicago company, largely owned by PMI, which got its COVID-19 vaccine rejected by WHO given the company's linkages to tobacco industry. And the company recently announced a disinvestment plan. In the next slide, the third area of industry activity identified was partnerships for reputational benefit, including with governments, health and development agencies, and even civil society. This reiterates the need to develop mechanisms to support authorities and organizations in managing their interactions with commercial actors. And even more, some companies try to give the appearance of partnerships, such as the gambling industry with their Play a Part Together campaign, pretending as it was part of WHO's recommendations for social distancing. And in the next slide, I will talk about the fourth and last area of industry activity that was identified in the report, which was shaping policy environments in the context of COVID-19. This included efforts to class unhealthy commodities and services as essential, pressuring to suspend public health and environmental regulation, and to accelerate emergence from lockdown and attempts to shape recovery strategies and the so-called return to normal. So in my last slide, well, that's not the last slide, but in the next slide, I will talk about very briefly how NCD has been leveraged this kind of findings in terms of their work, our work, around pandemic preparedness and response. So we had a global NCD agenda for resilience and recovery from COVID-19 recently with 12 key recommendations. Here I'm flagging only 3, given the importance of today's discussion, where the first is about the future pandemic work needing to be more coherent with related health and development priorities, including by effectively addressing conflict of interest and power imbalances. The second around the need to pivot to prevention to improve the health status of our populations, given that that has an impact on the human and economic costs of future health crises. And third, the need for social protection to overcome health inequities. But we need to have a long-term vision and keep the momentum. For instance, we saw good developments with the French government saying that domestic flights would be a ban in France to keep air pollution levels low. But the ban, the final criteria for this ban has been is very small, and at the end, it has not been as ambitious as initially expected. So on the last slide, I would like to, in the next one, sorry, which is the last one this time, I would like to conclude with a vision to building forward fair from an advocacy perspective. And as part of that, how we can address commercial determinants drawing on the lessons of this report. So first, we would like to highlight how governments need to stop blaming ill health on individual behavior. And I think that has been reiterated, but we shouldn't be only measuring the prevalence of unhealthy product use as an isolated phenomenon. So we also need to measure how different channels and strategies of marketing, ability, pricing lead to higher prevalence. Second, governments need to regulate all health harming industries. Self-regulation has proven not to work and should stop having differing approaches depending on the industry sector. All industries with commercial interests in conflict with the long-term public health interests pose a major risk to policymaking. And so third, all these health harming industries need to be the object in theory and practice of conflict of interest policies. And last, as mentioned earlier, coherence is addressed in addressing the commercial determinants of health across sectors is key. This demands including a health lens to all sectors of our government. This leads to a very recent example of what governments shouldn't do. The recent announcement that Coca-Cola will sponsor COP27 this November. Climate change, food systems, and health are heavily interlinked. And despite this, concerns about this incompatible partnership from a health and not just environmental angle haven't been necessarily visible. So I would like to conclude that the whole public policy mindset and narrative, as flagged by Greg in his introduction, needs to change beyond the health sector to effectively address the commercial determinants. Thank you, and please do read the report and reach out in case you have any questions.
Thank you, Liz. Fascinating. Hopefully somebody's put the reference to the report in the chat. If not, I shall do so in just a minute. I'll keep moving on in essence of time. I'd like to introduce Prof. Jeff Collin, who's going to talk around the between the conflict of interest and policy coherence in non-communicable disease governance. Jeff, over to you.
Yeah, thanks very much, Greg. And particular thanks to Liz for setting up my presentation so nicely. Both policy coherence and conflict of interest were very prominent in that account, which I think is helpful in illustrating what might otherwise look a slightly kind of academic and abstract presentation. I guess the key point I'm wanting to make here is that we need to do rather better about articulating some of the assumptions underpinning the commercial determinants of health if we're going to be able to leverage its potential to the fullest. And that's kind of what I'm trying to get at in engaging with both conflict of interest and particularly with policy coherence here. Next slide, please. So policy coherence is very helpfully enshrined as a commitment within the Sustainable Development Goals. Slightly less helpfully, it's also arguably the most marginal of the SDGs, at the same time as being the most central and most important. And it appears in a part of the SDGs where there's a whole host of things that actually undermine possibilities for policy coherence, sitting alongside commitments to trade, commitments to partnership, for example. So when we look at commercial determinants of health, we really are kind of dealing with some of the central tensions in global health agendas, which we often experience at national level too. Next slide, please. And again, I just want to kind of illustrate just how central this is to the SDG agenda. The Sustainable Development Goals are vast. They cover so many areas. So there's a real opportunity, particularly as time pressures towards meeting the SDGs increase, for those advocacy and policy areas that can generate big wins across a number of linked areas to really gather momentum and to utilize their ability to leverage multiple gains. So the commercial determinants of health is really all about identifying the indivisible, the reinforcing, the enabling factors across a whole host of linked health issues. And crucially also, this requires us to do a better job of articulating existing commitments, existing practices that constrain, counteract, or even cancel the potential of effective NCD governance. Next slide, please. So what do we mean by policy coherence? And apologies for belaboring this, but I think it is quite important for us to do a better job of unpacking what I think are really kind of implicit assumptions when we talk about commercial determinants of health. So generally, we're talking about in this space about horizontal coherence, particularly in this kind of context. We're talking about trying to promote coherence across specific health issues, notably NCD interventions and risk factors. But we've also got to be aware of how we can best promote synergies between health and other policy spheres. And also in a UK context, very importantly, how we can better promote coherence across strategies of devolved administrations and between national and local governments. I think it's really important for us to begin to pay rather more attention to vertical coherence, if you like, to ensuring that we do a better job of getting consistency between domestic health strategies and international strategic priorities. And given that the UK is so central in the political economy of unhealthy commodity industries, there's a particular importance of that. And also for a context like this, we've got to think more about interorganizational coherence, which I think the report Liz flagged does a really nice job of illustrating, some tensions in the existing politics of partnership with commercial actors, not just for governments, but also for civil society organizations that need to do a slightly better job of working through the implications of these agendas. Next slide, please. And it's particularly important, of course, because frankly, for a long time, there's been a very deliberate pursuit of policy incoherence in NCD governance, with tobacco being explicitly treated as very different in governance approaches to other risk factors. And there's been a major strategic divide that other colleagues have spoken to. Next slide, please. And we can see this playing out in the international NCD agenda through the sheer scale of commitments to public-private partnerships, about which the evidence base for effectiveness is really limited in general and very limited in an NCD space across the agenda, with the notable exception of, next slide, please. Tobacco exceptionalism. You know, governments should be encouraged to engage constructively with the private sector, brackets, with the exception of the tobacco industry, and with due attention to the management of commercial and other vested interests, which tend to get thrown in just as a kind of throwaway line to as a bit of a sop towards civil society concerns, but which we've got to pay much more serious attention to those tensions within the NCD agenda if we're going to move forward seriously. Next slide, please. And this is really important. And again, I was really pleased that Liz situated this in the context of broader discussions about the social determinants of health, because if we are going to unlock the potential of the commercial determinants of health to really move forward on a number of agendas, to, you know, what it promises is sites of effective, politically feasible sites of intervention that can move the conversation and policy actions upstream in new ways. But we've got to do a much better job of articulating what that means in terms of learning across and integrating across and collaborating across risk factors. Next slide, please. And we can see all sorts of areas for improvement if we just look at variation in our existing strategy. So for a long time, the UK government has had very clear guidance for overseas posts on not supporting the tobacco industry. And this is a particularly important example because this predates the FCTC. You know, we don't have to wait for an international convention before we take action in these kind of areas in other spaces. Next slide, please. But if we contrast this with alcohol debates, this is one of those little moments that still causes me significant pain. A debate that was held in the House of Commons a few years ago, initiated by the SNP, at a time when the Scottish government was locked in the most heated, horrible litigation with the alcohol industry, but nonetheless held a debate in Parliament in the context of debates around taxation, where there was very open commitment towards promoting the interests of the Scotch Whisky Association overseas. We've got to get much better at articulating these kind of tensions. Next slide, please. And Liz stole my thunder by highlighting the Coca-Cola example, which again is, on the one hand, is one of those moments where you think, surely not, this can't possibly be the case. But it's actually a really helpful example of the overwhelming logic, the scale of the political commitment to partnership at national and international levels. It makes perfect sense in terms of the strange logic of the SDGs in some respects. We've just got to do a much better job of challenging that logic and reframing it. Next slide, please. And this applies much closer to home as well. The William Grant Foundation, the philanthropic arm of Grant Whisky, are very prominent among partners, among supporters of breast cancer now in Scotland. And I don't need to explain the tensions of this to this audience. Equally, I don't need to explain the challenges that organisations like Breast Cancer Now are confronting, but there's got to be better options than this. Next slide, please. So I just want to kind of sort of reassert my academic credentials a wee bit by situating this in what I think is a really helpful framework developed by some Mexican scholars to unpack what we actually mean by policy coherence. And they actually distinguish three different types here from from coordination, the more modest form, to full policy integration in the other. And we explored this with reference to tobacco control in a recent paper in the 30th anniversary special issue. Next slide, please. But for the next couple of minutes, I really want to focus in on the idea of instruments. We've got to get much better at identifying policy tools that can work across different risk factors so that we can promote overlap and synergies across policies. We can get them to reinforce each other. We can use the same kind of tools to achieve similar goals across target populations across different risk factors. Next slide, please. And I want to suggest that from an overall health governance perspective, getting conflict of interest right is clearly going to be crucial in this space. And Article 5.3 of the FCTC is often cited as a starting point for this. It's often sometimes presented as if it's straightforwardly a solution, as if we really know what we're doing in this space. But actually, there's still a long way to go to fully leverage the potential of Article 5.3. Next slide, please. And with colleague Rob Ralston, we've been doing some work to really kind of unpack the kind of wish list of good things that Article 5.3 contains, and to think about, what are the central principles or norms that they include? What are the key rules for government officials and other policymakers in order to limit interactions with industry, etc.? And crucially, how do we move the conversation on to identifying better tools to support officials, policymakers, civil society organisations in managing conflict of interest more effectively? Next slide, please. And again, there's sometimes a tendency to suggest that this is done in tobacco control. This is, it's an impenetrable table at the best of times. It doesn't work very well in this screen. But the crucial point is that the white areas are the areas where there's absolutely nothing at all in terms of coverage of key Article 5.3 implementation recommendations, even within what constitutes best practice at an international level. Next slide, please. But we can nonetheless learn from this, and we don't, again, crucially, we don't have to wait for a framework convention in other areas to do this. So WHO have been putting work into developing a tool for managing conflict of interest in nutrition policy, which, while it doesn't have anything like the legal base of Article 5.3, can provide some really valuable tools for policymakers in thinking about through how they manage interactions with industry, and crucially in justifying those decisions to other government departments. Next slide, please. And the final one, if that's all right. Oh, sorry, that's not quite final. Canada provide a really lovely example here of how we can, just kind of on the hoof, make decisions that can help to manage interactions with industry much better. Canada chose not to consult with the commercial sector in developing its new food guide. Next slide, please. And very finally, this matters because if we get this right, we can identify new opportunities for shared opportunities for innovation in health governance. We can tackle vectors more effectively. We can create with all sorts of agendas, crucially including the Healthy Cities agenda, in new and more effective ways. Thanks very much.
Thanks, Jeff. I shall move on to the last speaker of this session, then we'll get some Q&A. So in this session, you get a double act, 2 for the price of 1. Will Anderson will start us off, and then Hazel Cheeseman will finish the session. So Will, over to you.
Thanks, Greg. I'm presenting the findings of a small study, recent study, looking at the pros and cons of taking a more integrated approach to tackling risk factors for non-communicable diseases, which follows neatly from what Jeff has been talking about. And I should say that the language of a more integrated approach encompasses all the possibilities which Jeff identified: coordination, policy coherence, and policy integration. Next slide. Thank you to our funders. Next slide. It's funded through the Spectrum Research Innovation Fund, led by the 3 main coalitions for tobacco, alcohol, and obesity. Most of the conversation in this study was about those 3 subjects, but not exclusively so. Next slide. So to reiterate, we were exploring public health stakeholders' experience and perceptions of the barriers and facilitators to taking a more integrated approach to tackling risk factors for non-communicable diseases. Next slide. Small qualitative study, 14 participants, interviews. These were both in government and in NGOs, both at national and regional level, and both in England and Scotland. Next slide. These were all public health professionals, but they had a diversity of views reflecting in part differences in their experience of taking a more integrated approach, their attitudes and beliefs about how best to intervene to achieve public health outcomes, and the locus of their work and the breadth of their interests. Next slide. So just some examples of their experience. We had a member of the coalition responsible for the creation of the Scottish Parliament's cross-party group on improving Scotland's health, where this is happening to some extent. We had Yorkshire and Humber's Healthy and Fairer Futures programme represented, which does have a focus on commercial determinants. The Joint Fresh and Balanced team in the North East, tackling tobacco and alcohol. The Royal Society of Public Health, Health on the High Street programme, which takes a place-based focus. And the Mental Health Foundation, which has looked at the effects of a range of industries on the impact on mental health. So quite an interesting range of experience. However, all participants acknowledged that this was to some extent the exception rather than the rule. Next slide. In practice, to be honest, they seem to be approached very much as individual areas, despite the fact that they share a lot in common, particularly around the social determinants or the commercial determinants of health. I think the only time they come together is when you're talking about something separate that they're all relevant to. For example, around the time of the government's Green Paper on Prevention, there was a bit more of a concerted effort to bring things together. Next slide. So why do this? Well, there are many kind of ways of thinking about this. There's the clustering of risk factors at an individual level. There's how that clustering turns into health inequalities. And of course, there's the big focus on the commercial determinants within the wider socioeconomic determinants of population health. All these were discussed, but given who we were talking to, public health professionals with the population view, it was the last of these which was the main focus of discussion. However, there wasn't a kind of complete consensus about the last of these and how these two relate. Next slide. Does a focus on the wider socioeconomic determinants of health provide a clear framework within which to specify action on the commercial determinants? Or does it draw focus from commercially driven risk factors, or even relegate and obscure the commercial determinants? All these possibilities were discussed by our participants and reflect some of the discussion earlier today. Next. There were some very clear differences in people's views depending on where they were active. Should we take a more integrated approach? This is both in advocacy and in policy making. Those close to government in England had serious doubts about this. In Scotland, they were enthusiastic and committed. Regionally, people were optimistic about the added value, and in the non-governmental participants, mixed views, but definitely keen to do more. Just give you a couple of examples next. So nationally in England, I think it gets very, very difficult because the national government sees these things as, right, what's our next activity on smoking? I think a collaborative approach would show a united front and everyone would feel they were working collaboratively, which everyone in the world wants. At the same time, would it make their policy asks undeliverable because the system they are talking to doesn't work in the way that they are presenting themselves? Next. More regional perspective, local. I think local councils and local communities are more open to taking a joined up structural approach and looking at how they can maximize budget funding pots to create a more healthy community-based environment. And some of the actual practical decision-making around those commercial determinants are locally led. Next. So, benefits of taking a more integrated approach: a stronger voice and wider buy-in, greater alignment of policies or campaigns, and more efficient ways of working, learning from each other, and crucially, opportunities for reframing. So some examples next. There's no doubt that there are people around the table who may not have come to the table if we'd just been talking about alcohol, for example, but they're interested in smoking or they're interested in obesity. You broaden the conversation and bring people into the conversation who wouldn't otherwise be around the table. Then there are MSPs who are interested in cancer, for example. Oh, so cancer research are putting their weight behind this report. It gives us greater clout and broader reach. Next. It makes sense for us to go to health and wellbeing boards, for example, and speak on both agendas. And, you know, there's been a lot of progress within the Northeast on tobacco. So having that as an illustration helps us to move forward on the alcohol side. So when trying to influence local authorities, it does help to join up the agendas. Next. One of the most fundamental things is the framing. The narrative is dominated by industry. It's just these people over here who don't know how to control themselves. That kind of individualized blaming and shaming versus these are multi-billion-dollar industries who are ramming this stuff down people's throats. We shouldn't expect companies to be moral beings, but the bottom line is that the power and influence they have is undermining people's human rights and causing death and misery. That's the reality. Helping people understand that is like peeling the scales back from their eyes. Next. Okay, problems, obstacles. The dilution of the power of single issue advocacy. Differences across risk factors and policy progress, public attitudes, and industry access to government. The difficulty of tackling commercial determinants, including conflicts with economic strategy. The practical challenges of bringing people together who have diverse knowledge and interests, political uncertainty and turbulence, and language and communication issues. Some examples next. Our relationship with obesity and our relationship with smoking are very different. Smoking is much more about how we stop anyone smoking because fundamentally it's not a great health choice. The relationship with food is so much more complicated. And I think that creates some tensions. You need to have opportunities for a really broad conversation and opportunities for quite a specific tailored conversation. Next. For me, the biggest frustration is the way that the industries are perceived differently at a national level. The tobacco industry is very much excluded from policymaking, whereas the alcohol industry is much more embedded with government. Arguably, the biggest challenge is trying to shift those perceptions. Next. One issue with commercial determinants and these industry forces is that for many people, they feel too big, they feel too difficult to address or change. What I have found in my experience is that there are actually areas where you can achieve small shifts, and these could have big benefits. Next. So drivers and opportunities identified. Declining funding for NGO advocacy organisations is a negative driver. Integrated care systems in England, the public health bill in Scotland. There's a lot of opportunities within existing activity in local government. There are the new national public health agencies and recovery from the pandemic. I put the last two in brackets because they've somewhat faded from view since this study was undertaken in spring this year. Next. So some concluding points. The relationship of the commercial determinants to the wider determinants is not settled in public health debates. However, a shift in focus to the commercial determinants opens up new ways of thinking about tackling NCDs. There are many benefits to taking a more integrated approach to tackling NCD risk factors and their commercial determinants, but campaigns and policy still need to be tailored to specific risk factors to some extent. And closer working between agencies and/or policymakers could include anything from better coordination and information exchange, alignment of aims and target populations, sharing of skills, techniques, and advocacy tools, through to full integration of organizational priorities and goals. Thank you. This study was conducted by Ash, and I think Hazel would like to say a few final words.
Well, so I'm Deputy Chief Executive at ASH, and we coordinate the Smoke-Free Action Coalition, and this work was undertaken collaboratively as well with the Obesity Health Alliance and the Alcohol Health Alliance. And I wanted to highlight the fact that this was obviously a small piece of work, but we are planning to build on it, and we have some funding from Cancer Research UK to look at developing something which addresses, I think, some of these challenges around policy coherence. You know, how do we move from the tobacco exceptionalism to applying the lessons of tobacco control to the wider commercial determinants of health. So we are taking on that challenge with some funding from Cancer Research UK. We're looking at developing a strategy over the next 6 to 9 months. some further research on the economic side, and we have an advisory council which is kindly chaired by Professor Linda Bald. And so to highlight that this work is ongoing, that we are looking with a focus at national policy, but collaborating with others who are taking a more local government perspective as well, to build that vertical policy coherence that Jeff was talking about, as well as the horizontal policy coherence. So watch this space, and if people think they have something to contribute to that discussion, then we're really keen to hear from them. And I will leave it there.